Hello, I'm Matthew Hill, and this is my colleague Joe Scott. And in this session, we'll share the findings of the recent Q Insight survey, where we explored what the role of improvement in supporting change during COVID-19 has been. And crucially, what does this mean for the future of improvement? So right from the start of COVID, we heard competing narratives emerging, with some seeing the pandemic as improvement's moment to really come to the fore, and other narratives seeming to suggest that improvement, or at least certain elements of it, were being bypassed. So we wanted to know more from you, the Q community, about your experience during the pandemic, and use these findings to help develop how we all think about and support improvement. We sent the survey to all members in the summer with a range of closed and open questions, and we received 225 responses from a range of roles, organisation types and countries of the UK and Ireland. We want to say a huge thank you to those who took the time to share their experience with us. Some of the findings are pretty clear, and we think have really clear implications for us all as improvers. But some of them are more tentative, and we want your help to interpret the results further and make sure we're learning the right lessons. We very much see the findings presented here as a contribution to the conversation that we need to have as a community, not the final word. So firstly, we'll hear about the important role improvement has played and explore which improvement tools, methods, approaches and mindsets have been most useful and which have been most challenging to apply during COVID. We adopted that broad framing of improvement tools, methods, approaches and mindsets because we were keen to capture as wide a range of experience as possible. We know it might not feel quite right for some of you, but if you'll allow us, we'll use the term improvement as shorthand for this broad definition for the rest of the presentation. We'll then hear about the enablers of improvement and how having a well-developed approach to improvement pre-COVID appears to have supported its application during the pandemic. Then, to make sense of the findings overall, we really want to test two more tentative conclusions with you. So firstly, we'll ask whether a crisis standard of improvement has been applied. And secondly, we'll explore the relative importance of improvement methods versus improvement mindsets. In fact, arguing that for some, it's more accurate to characterize the role of improvement during the pandemic as functioning like a muscle. And finally, we'll hear what improvement priorities and challenges lay ahead for us all in the improvement community.
So our first really clear finding is that improvement had an important role in supporting change during the response to COVID-19. 81% of members felt that improvement had been moderately or very important. And as you can see from this graph, overall, more respondents said that the role of improvement increased rather than decreased or stayed the same. In terms of how improvement was applied, the responses suggest it was used to the greatest extent for rapidly reviewing and improving processes and practice. The model for improvement, and specifically use of PDSA cycles, were mentioned as being most important for this purpose. However, respondents also reflected on challenges. While the PDSA framework was considered useful by some for its flexibility and simplicity, others reported that it was applied incompletely, with some stages being missed out, as people are moving too fast to think about the learning generated before making their next plans. Improvement was also widely used for engaging staff and enabling teams to work effectively together. This showcases the benefit of improvement for its focus on the people involved in change. Tools that support open and frequent communication, such as huddles, after-action reviews, Schwartz rounds, and different liberating structures, were useful for promoting psychological safety and staff well-being in a stressful and rapidly changing environment, and engaging staff when there was limited time available. However, with redeployment and remote working resulting in a different team setup and the immediate pressures during the peak, some found it harder to get input from the right people. This includes staff, but is especially true for engaging patients and carers. So in terms of the less common applications of improvement, while almost 2/3 of respondents used improvement for measuring what was happening, this was also one of the greatest challenges mentioned in the free text responses. This was due to time and access to collect data and analyst capacity to enable interpretation and use. And engaging patients and carers, while this is something that is arguably low anyway, people's ability to do this was made more difficult by the pace of change and the social distancing restrictions. So as you'll be picking up, there are contrasting and at times contradictory experiences. and this is worth considering. The responses raise questions around short-termism. Respondents' comments emphasise the application of improvement tools to short-term immediate changes, and perhaps understandably, longer-term, more transformative programmes and training were paused. And some reflected that it has been hard to restart these. We're interested in finding out more about what, if any, are the implications of this. Another important consideration is fidelity to tools and methods. Did improvement increase because people were not systematically or faithfully applying them? And to what extent does this matter? The context of remote working is important. While some stated that this supported greater collaboration, enabling reach and collaboration is usually more difficult with geographical boundaries, others reflected that this made it more challenging to apply certain tools and methods and engage people effectively, which undoubtedly held some people back from applying improvement systematically. So on to our next key finding. The responses suggest that those with more established improvement cultures and capabilities did respond differently. Based on our analysis of the different questions, we surmise that respondents said that improvement had been very important, were more likely to have a well-developed improvement approach within their organisation. And these respondents were more likely to have used improvement tools for planning for the future and deciding where to focus efforts, both more strategic applications for improvement. They were also more likely to report using it for engaging staff and enabling teams to work effectively together. It's also correlated with increased collaboration. They were also more likely to agree that they had been able to make use of their personal capabilities and their teams had applied a systematic approach. However, when we are considering what we and others need to do to build on the learning from this time, we need to understand just how prominent the other enablers are. I'm sure many of these descriptions will be familiar to you, as they've come up again and again in our work to understand what enabled the rapid change in the immediate COVID response. And it adds weight to the existing evidence that highlights that the organisational and system context in which the skills and principles of improvement can be applied are just as important as specific technical learning and soft skills. So what I think this tells us is that we need to continue to invest in and develop skills for improvement, but we also need to give enough attention to influencing and enabling the system conditions in which improvement can thrive. Matt will pick up more on this shortly, but first we want to consider what we've learned about leadership.
Thanks, Jo. So there's no doubt that the results support wider emerging evidence that tells a positive story about the emergence of new forms of leadership during COVID, in teams, in organisations, and at the system level. Forms of leadership that offered autonomy to teams and inclusive and compassionate leadership were both identified as key enabling factors for respondents. In the more detailed responses, we saw a range of factors that underpinned this, including setting a shared purpose, removing existing reporting or regulatory barriers, providing resources, and adopting a deliberately more permissive culture. And this all resonated well with some of the Health Foundation work that identified top-down clarity and bottom-up agency as a key factor in supporting positive change during the pandemic. Yet this was far from universal. So those who had faced greater challenge in drawing on improvement during COVID often described a command and control style leadership in their organisation that had really held them back. Now, as well as stifling a culture of testing and innovation, this clearly inhibits improvement tools that aim to engage stakeholders in diagnosing the key issues and co-developing potential responses because they were predetermined by leaders. And so leadership clearly played a crucial role, but we actually think there's a lot more work to do to really draw out the detail of exactly what it took to achieve more enabling and positive leadership, a theme it'll be great to pick up throughout the event. So now we want to test two more tentative findings with you that try to understand the responses overall. We hope they'll really help us to learn the right lessons from the crisis, but would be fascinated to hear how they land with you, so please do let us know. Firstly, it was clear that due to the constraints of the crisis context, so the required rapid pace of change, the uncertainty, and the challenges of remote working, many respondents applied improvement in a really quite flexible and limited way, sometimes with quite low fidelity to what we might think of as the gold standard of improvement. And this led us to ask to what extent a crisis standard of improvement was applied. So this draws on the concept of a crisis standard of care and asks, given the constraints of the crisis, was the best possible standard of improvement applied? So if we think about measurement, there were clearly constraints, weren't there, on data collection and capturing longer term outcomes. But we think it's clear that some respondents applied a better crisis standard of measurement for improvement than others. So although for some, measurement was limited to informal feedback with staff, others went much further and collected systematic data on levels of engagement, as well as certain quality metrics such as staff and patient satisfaction. Similarly, many felt the crisis constraints prohibited patient engagement, but others adapted existing tools and developed new ways to engage patient voice and experience during COVID, albeit to a perhaps more limited kind of crisis standard. And thirdly, we think it's an open question what the crisis standard of the model for improvement is. Clearly, many used it flexibly and very usefully, but there likely comes a point where if it's used in an overly partial and limited way, it actually loses its value, even in a crisis context. So we think by integrating the crisis context and constraints into our assessment of good, it allows us to make more sophisticated judgments about the role of improvement during COVID. And we hope allows us to learn the right lessons, so that although some of the more limited and partial approaches to improvement have been effective and appropriate during the crisis, that doesn't necessarily mean they're the best standard of improvement for the longer term. A second overarching question we applied to the results was whether improvement methods or improvement mindsets had been more important during COVID. Now, as we heard from Joe, a wide range of really quite specific methods had been applied during the response to COVID for a whole range of purposes. So for some, COVID will absolutely have reaffirmed their confidence in rigorous improvement methods. However, the dominant view amongst respondents was that it was the broader improvement mindsets, such as system-wide thinking, Pareto principles, and really scrutinising whether changes really are improvements, that were the key in supporting positive change. Indeed, some felt that the more rigid, technical, and niche methods were not really very useful at all in the crisis context. So some did explicitly kind of set up that method mindset tension. But there was also the third narrative that emerged, and it came through quite strongly from some responses. And this goes beyond that tension between methods and mindsets. Instead, it frames improvement as functioning as a muscle during the pandemic response. And I think these two quotes illustrate it well. So one respondent said, what was encouraging was that you could observe methodologies being used almost as a heuristic rather than through any planned desire to follow a strict methodology. And another said, there simply wasn't time to devote to ensuring accurate measurement or implementation or even plan. But it was as if muscle memory kicked in for a lot of the team. So again, we think this is a useful framing. We heard, didn't we, that those with a more well-developed approach to improvement pre-COVID, or you could say those with the biggest improvement muscle, saw a bigger role for improvement during the crisis. And not to push the metaphor too far, but it also appears that some had a more supple improvement muscle and were able to flex their improvement approaches in a more sophisticated way by applying a more effective crisis standard. And I think finally, to some extent, it helps to overcome that method mindset tension. Because even if we conclude that it was mindsets that were most important during the crisis, I think we know, don't we, that actually one key role of improvement methods is that by learning them and applying them in practice, it really helps to build that improvement muscle that can then be more easily flexed in different contexts. So we'd love to hear your thoughts on that. And I think it's crucial, isn't it, that we do learn the right lessons about the overarching role of improvement, and that non-improvers learn the right lessons too. And indeed, some of the respondents expressed concerns that some non-improvers may look at the sheer scale of change that's been achieved during COVID without applying improvement tools and methods, and actually conclude that perhaps they're not so important after all. So now turning to the future, we asked respondents to choose the 3 issues that they think the improvement community should prioritise. We can see that the top 3 were working in a more integrated way across teams and organisations, and that really builds on the higher levels of collaboration that we've seen during the pandemic. Second top was introducing digital innovations effectively, and that's probably the most widespread service shift during COVID. And thirdly, the importance of embedding systematic approaches to improvement within health and care organisations. Perhaps more surprisingly, reducing waste, supporting self-management and prevention all came quite a bit lower. So this gives us some useful data, I think, on your priorities, but we clearly need to explore them with you all in more detail, including as part of this event. And finally, we asked respondents what the biggest challenges were to embedding improvement in the continued response to COVID over the next year. There was a combination of new challenges directly related to COVID, as well as lots of pre-existing persistent challenges. Firstly, and I think overarchingly, one of the biggest challenges that respondents mentioned is ensuring that the system really understands how positive change has been achieved during COVID and acts on those findings. And as we said, there's a real responsibility on us all, isn't there, in the Q community, to learn those right lessons and confidently communicate what we think these lessons are. There were also challenges identified for improvement itself. So respondents felt improvement needs to be proactive to capture the digital turn across society and across healthcare, ensuring that improvement tools are adapted, and there were some good examples such as liberating structures around that equipment is provided, and that there is a focus on building the digital capabilities of improvers. We'd probably add to that given the challenges around measurement that we identified, there's a case for a focus on building analytical capability within improvement. Do we focus enough on this in Q? I'm not sure we do, so that's an interesting challenge, I think. And then thirdly, for some of those who'd only been able to apply improvement in a more limited way, there was a feeling that now was the time to bring improvement back, whether that's in patient engagement, systematic measurement, or applying improvement thinking to longer-term complex challenges. Finally, there were a range of challenges around leadership for improvement, with a call from some that improvement makes a more direct contribution to both system priorities and the priorities of those on the front line.
So we've covered a lot of ground in this short presentation. We've highlighted how the survey does provide evidence to show that improvement had an important and increased role during the response to COVID-19, and there were benefits for how those with established improvement cultures and capabilities were able to respond. But there are still many questions to explore. What are the implications, if any, of some of the challenges and issues raised about fidelity, short-termism, and leadership? And how should we respond in terms of our individual practice and as the Q community? We want to continue these conversations with you throughout the event and after. We will be sharing a report with more details on the findings that we've presented here and intend to explore further some of the outstanding questions that we have with interviews and some further conversations with you. So do get in touch via email or on Twitter. Thank you.